All good on the Zoom in too. So please let me know if you're not seeing my first slide, which is the opening slide. And we're so glad to be on that slide. I'm just going to use this from now on. No more touching the computer. On Zoom, can you guys see that first slide there with the title? Perfect. So thank you, with a little bit of delay. Thank you, Marlene, for that wonderful introduction. And I'm so grateful to be here with you and to speak about my work in health literacy. And really excited to share you about the work that we've been doing at Children's over the last several years. So this clicker isn't quite working. Angie, you help me with that? Is this one hooked up to work? Go. There we go. Should we connect to it? Do you dare touch? I know. Okay. That's okay. I'll just use your computer. We're bound to have some technical snafus, but that's okay. We're back in person, right? So they happen and we get through it. So tonight I'm going to talk about and help you to understand the impact of health literacy on health outcomes, describe ongoing health literacy focused organizational efforts, and then describe systems-based strategies, the things that we're using and others are using nationally to improve organizational health literacy. So why are we doing this? And I think Marlene gave a really great example of, the things that we think, oh, all right, we got that working. The things that, the discoveries that we make, the medications that we prescribe, the information that we pass on to our patients, if they don't take that in and actually apply it in their life, what we do, it actually isn't going to impact the care like we would want it to. But these are some examples of why this impacts what we do every day at Children's. A family misunderstands how to give their daughter her home medications and gives it 10 times overdose. Now imagine this is a 6-month-old after surgery and it's oxycodone. And that patient's in the ICU. These are real cases, by the way. A mother comes back to our emergency department because her child gets a new G-tube and she has to give her child their medications, their feeds, and just simply didn't know how to unclamp the G-tube, didn't understand how to work it. Where do they come? They come to the emergency department. Or a grandparent didn't know how to manage a life-threatening emergency or when her grandson's trach gets plugged and causes further devastating medical issues. So we think about all of these in the context of the safety and the quality of the care that we provide. And these are all examples of where communication broke down and we didn't get that point across of how to do all of these different elements in their care. So how do we describe health literacy? It's actually been a term that's been around since the 90s and has various evolution of definition. So the one I'm providing here is from Healthy People 2030. Healthy People 2030 provides this definition, it's evolved a little bit over the last 10 years, but it's the degree to which individuals have the ability to find information. So I'm going to stop on that word. So it's not just, we think about literacy and we think, well, it's all about reading, right? But it's not just about reading. So first thing is we got to find it. So that includes seeking out information, looking online, where are they getting their information from? Is it good sources? People who have not as good of health literacy are not using good sources. So finding that information, then actually taking in that information, understanding it, and then using that information to make decisions, making health-related decisions, and then actually making those health-related actions for themselves. And in the context of pediatrics, they're making those decisions for others. But that is in a lot of medicine, there are caregivers that are providing and making health-related decisions for others as well. So what does this look like? When we look across the United States, here's kind of a map of what this looks like. Unfortunately, we haven't had really good health literacy national data measured since 2003. And we'll look at here from a Milwaukee standpoint. So this is the city of Milwaukee. The red is the lowest quartile of health literacy, orange quartile 2, and the greens are quartile 3 and 4. And so what we see is we see that there are pockets and areas where we have had systemic problems with how we have created issues with our educational system, with our housing, and how we have created areas of oppression, that we also have created issues with health literacy. So these areas of our city and of our nation, they have not been able to have the health that they could have because of health literacy is one of those reasons. And so we think about this as an equity issue. So clearly there are areas in our city and in our nation where there are pockets where there are people who have lower health literacy. And how does that play in with health equity? So many of the same factors that influence health literacy or are associated with health literacy are also associated with health equity and health outcomes. So those individuals with race, ethnicity, of minority race or minority ethnicity are more likely to have lower health literacy. Lower educational attainment is likely to have lower health literacy. In poverty states, more likely to have low health literacy. Having a language that's other than English as a primary language, they're more likely to have lower health literacy. So the interesting thing about age is actually with health literacy, we see kind of a bimodal distribution with younger ages, especially like younger age parents, they're more likely to have lower health literacy, and then older ages. As we see literacy, vision change, we see health literacy changes as well. So how do all of these impact health outcomes? Well, we see that individuals with low health literacy have more emergency department visits, more hospitalizations, make more medication errors. They have worse overall health and higher mortality rates. They have more missed appointments, less preventative care, higher healthcare costs on the order of $200 billion a year. I'm just going to point out that all of these data points come from a review article from 2004. We've really known about this for 20 years. We've known that health literacy impacts healthcare in this strong of a relationship for 20 years. But not only that, health literacy is a stronger predictor of health outcomes than race, ethnicity, income, or employment. So all of those tidbits I shared on the previous slide, they've all been adjusted for all of those factors. So race, ethnicity, income, and employment. This statement comes from this report that was in JAMA in 1999. The Ad Hoc Committee on Health Literacy for Council of Scientific Affairs noted that health literacy is a stronger predictor of health. But I think what I take from this and what is really important about this is that we now know and we have the capacity to change and work on from our institutional and our personal perspectives how we address health literacy. And this is something we can actually do something about. In pediatrics, it's definitely the same kind of health outcomes that we've seen. Like many things in pediatrics, it comes a little later, the research. We've had a lot of the adult research, and then we find these kind of things in children as well. And most of this that we're looking at is parent related, but also many teen pieces as well. So this is just a summary from a review article that we did in Pediatrics in Review that was published in 2019 across health knowledge, health behaviors, health outcomes, after adjusting for race, ethnicity, income, and poverty status. We find that parents have less topic-related knowledge about pediatric conditions. They perceive their child to be more ill when they're sick. They have worse safety behaviors, like things that pediatricians talk about, like turning down the water heater, having a smoke detector in the home. They have worse feeding, nutrition, healthy weight behaviors, and in teenagers, more likely to use tobacco, alcohol, and those teenagers have more violent behaviors such as carrying guns. And then with health behaviors, parents will make more medication errors, such as not understanding how to dose liquid medication, which can lead to a lot of dosing errors with kids. And then just worse disease management overall, such as in diabetes, like type 1 diabetes. They have children of parents with low health literacy will have a higher hemoglobin A1C. And then in health outcomes, greater prevalence of disease, worse child disease specific outcomes, like worse outcomes for children with nephrotic syndrome, greater healthcare utilization. I've done quite a bit of research in this, looking at emergency department use, and children of parents with low health literacy have higher emergency department use. and then just worse healthcare access overall. So the moral of the story is that we have research that can point us in the right direction. We know that there are recommended communication strategies, and we know applying these can help. I'm not going to go specifically into what are those things on an individual level that you can do, but here's kind of some of those overall picture of what you can do from a communication standpoint. But we think about doing this as a universal precautions type of application. So just like we would for bloodborne pathogens, you put on your gloves, you make sure, and you're cautious with that. With every patient, we really should be communicating in a way that's very clear. And so that's a very important way to kind of view how we should, as a healthcare system, be communicating with patients and families. If you'd like to know more about any of these, we've detailed them really, really in-depthly in our review article as well. So that's a great reference point for that. So this is where we really think about and talk about, where does our healthcare system come in? So when we talk about health literacy and the definition that we've used so far, it's a little bit talking about it as a deficit, right? Like, well, these people have low health literacy. Ooh, what are we going to do about that? And that's not a really great way to focus on it, because we have to think of, we have to meet people where they are, and they're coming with their strengths. They're coming with their love for their family members, their community, their child, whoever they're caring for themselves, wanting to be healthy. So there's a lot of strengths that they're coming to, but it may not be with health knowledge. So their families, as we have pictured here, they're coming with their skills, but really it's how also that interacts with our healthcare system. So how difficult are we making it? How clear is the communication that we're providing? What is that like for them? And it's really the interaction of what their skills are and how our healthcare system, the complexity of that is where we actually get at our health outcomes. And so what the Healthy People 2030 uses as a definition, and has actually been used by the AHRQ and the Institute of Medicine Roundtable on Health Literacy, has focused on, well, how do we become instead a health literate organization or a health literacy focused organization? So where's our part in that equation? So that's where this definition kind of comes in, is as an organization, and I want you to think about whether that is your personal practice, whether that is, for me, that's Children's Hospital or Children's Wisconsin. That's where I work. That's the organization that I am trying to become a health literacy focused organization. How are we becoming an organization that equitably enables individuals to find, understand, and use information and services to inform those health-related decisions and actions for themselves and others? And so instead of saying that, well, they're supposed to do that, we're saying, well, we should be doing that. We should help them be able to do that. So what does that look like in a sense of how do we actually make that actionable? So this is the 10 attributes of a health literate organization that is written by a group from the AHRQ. And this came out in 2012. And there's a few different papers that have kind of working papers that have come out that even have more pieces of this that can help you really give you distinct actionable pieces to work on within your practice. But number one, the first thing is it's important to have leadership that makes health literacy integral to the mission, structure, and operations. If your leadership isn't on board, then it's going to be hard to advance this. And then what's really important is integrating health literacy into planning, evaluation measures, patient safety, and quality improvement. So I would say that I have spent the last 10 years doing these first two things. So leadership means that I have spoken at every leadership area possible at the hospital, every leadership person at the hospital, trying to talk about how important this is, and then work on integrating it into our quality and patient safety, which is really how we can make health literacy a focus of our organization. And then preparing the workforce is the next important thing. So it's not just about putting it as part of our planning and evaluation, but each person out there has to be responsible for this as well as part of their work and as part of their daily work. Because it's not as if one quality project or quality program is going to be the thing that changes our organization. It has to be the workforce as well. The fourth, including populations served, is very important in how we design and implement information and services. Number five, meeting the needs of populations with a range of health literacy skills while avoiding stigmatization. And I would say also that I think this also applies to when thinking about diverse populations. If you're an organization that specifically focuses on, say, refugee populations or populations of a certain culture, you need to meet the needs of your population, whoever they are. And you need to talk to them, because the same materials and the same information that you would give to someone in one area of our city does not suffice for someone in another area of our city. And how they think and deal with something as simple as asthma is completely different. And so you really have to focus on what the population is of your area and of your population that you serve. And then using health literacy strategies and interpersonal communication. And that's getting at those kind of universal precautions with everyone. And providing easy to access health information, designing and distributing print, audiovisual, and social media content that's easy to understand and act on. That is something, for instance, that Children's Hospital has done very well for a long time with having a very robust education services department. But there's a lot of other hospitals that haven't focused on that. All of our education services materials, they've always been at a 6th grade level. We've always done that at our hospital, but that, or I shouldn't say always, because I don't know how far back that always goes, but we've done a really good job of that. But I know a lot of hospitals aren't at that level. Addressing health literacy in high-risk situations, including care transitions. And the last, communicating clearly what health plans cover and what individuals will have to pay. And that is also become a stipulation in some of the recent laws as well. So there's a lot to unpack in each of these. And I would say anyone who's trying to do this work should just start with one. Just start with one and start with one thing and go from there. But how we view these is we actually use these as key drivers in our quality improvement program. We come back to and evaluate and see where we're at with each of these and think about what we've focused on and where we have been and where else we need to focus on in these attributes. So when we really looked in, probably about 2015 or 16, we realized we only focused on the top 3 and realized we really needed to focus on some of the other attributes as well, which helped kind of direct our work in a different way as well. So I'm going to move on and talk a little bit about what has been this work and a little bit about this journey and where we are today in working through becoming a health literate organization. So the effort I'm going to talk about here is health literacy related safety events, which is a qualitative study of health literacy failures and patient safety events. So we use this as an effort to show leadership the importance of health literacy at a local level, because it really is important. I've found that it isn't just national data that impacts it. We really need some local data to show people how important this is. If you're interested in reading more, this was recently published last year, and you can read more about this. So why do we focus on safety? Well, communication errors are a major factor in up to 70% of adverse events. And we know that inadequate information exchange can have tragic consequences. We've talked about already some of those instances. The interesting thing in patient safety is when we look at the safety the communication category in safety, is it includes interpersonal, like between medical personnel, and if it were to occur between a medical personnel and a parent, family, or patient. And so it's a very broad category and really doesn't break it down into that actual communication between the healthcare organization and the patient or family. And so we really wanted to describe that impact of health literate communication on patient safety and then develop themes to help us aid the prioritization of health literate safety practices. So we used our safety events database where we had tagged events for health literacy. So this is our system has a self-report database, and we had a safety specialist that goes through every event, looks at each of them and provides tags for them. People who put them in also can provide kind of these tags that say, okay, this was a communication event, or this was a medication event, this was an IV event, those kind of things. We had the benefit of the person who was in that role, which is why we chose to do this project also, had been on our health literacy task force for about 8 years, really well-versed in health literacy, really interested in safety. And so she had tagged all these events. So then we retrospectively queried and looked through all of those. And then we completed a qualitative content analysis. And we, again, like 3 of us looked at all of these and made sure they also were health literacy events. We all agreed. So if you know anything about safety events, they're very underreported. But what we know during that study period that we retrospectively looked at, health literacy related safety events occurred at least 4 times per week. So this is at minimum, at least 4 times per week. And when we look at the type of events, the main themes of those events were a broad category of medication. So about half of the time they were medication related. Another quarter of the time, approximately, they were discharge or transition related. So at that time of either discharge from the hospital or leaving the emergency department or discharge from clinic. And then the other quarter of the events were from health systems processes. So patients not understanding things like prior authorization or where to go or how to do certain things within our health system. And we didn't help make that clear for them. So the definition, I'm just going to talk about each of those kind of event types. The definition of a health literacy related medication event, the definition we used was it exists when the health system, staff, or care provider doesn't provide or ensure effective communication occurred when patient and or family member, guardian, when seeking medication information or providing medication information. Now, there's this big word in there, or this big phrase, effective communication, which maybe we know what that is. I don't know if we do or not, but I will tell you what, JACO has a really good definition of it, and it's a paragraph. So that is kind of an appendix that we have on this definition, is effective communication. In order to really, when you really get down to it and think about it, it's an exchange of information. It's a back and forth. It's not a static. It's not a static thing. And so that's how we describe what that medication, what those medication events are. So those sub-themes that we noticed or that we found were mistakes on admission medication reconciliation. Sometimes those are carried forward. For an instance, an admitted patient received double medication dose for over a week because we didn't take a really good history when we admitted them, or unclear discharge medication instructions. And we saw this a lot with weans and tapers. So we were asking people to go up on medications or down on medications. It was confusing. They didn't understand it. They came back and were readmitted because their seizures weren't under control, for instance. The medication instructions where they were given multiple instructions, for instance, prescription medication bottle and discharge papers had different information, but then there was another document that had something else. So when we give all of these different things with different multiple conflicting instructions, it's not surprising someone would make a mistake. And then there were some immunization specific safety errors related to communication, and that was kind of a category on its own. So the events that are around discharge transition, you'll see our definition of this is very similar. It's that we didn't provide that effective communication at discharge or transition home. This was with sub-themes of unclear equipment information, unclear teaching about the after visit needs, such as not receiving clear information on how to collect or prepare for labs done after hospitalization, which led to a delay, or unclear information about how to do bolus feeding, but patient actually has an NJ tube and can only receive continuous feeds. So they didn't even get information about how to give the feeds. And then health system process events. So things like navigation assistance, like keeping blood bands on after a blood draw. So the patient had a procedure delayed because they didn't have their blood bands on, so they actually couldn't do their procedure, or failing to address a language barrier when needed, or relying on parents for information what was in the chart. And then that led to misunderstanding and a medical procedure not happening that should. So what we really learned from this were areas that we needed to prioritize around organizational improvement. It also helped us take this to leadership and say, look, we see these areas and we think we can improve them. And it really helped us to acknowledge that we could improve our reporting of health literacy safety events. And we use these to develop additional performance standards around health communication. Right now, specifically, we've only done it for medications at this point, and develop a policy of health literacy best practices. We've also been trying to work with some of our national organizations to try to get a national reporting mechanism up for this, so we can start working this on a national group to try to improve these across other children's hospitals as well. So this kind of helped us move our focus forward. And I think that you can probably see one of those pieces is medications was a clear thing because those are half of the events that we saw. But one of the other pieces that we were really working on was our staff training. And so our health literacy task force had actually been doing a lot of staff training since about 2006, really ramped up around 2011, trying to touch every nursing physician group at Children's, as well as getting part of central orientation, but really had no kind of defined method of doing this and really no good outcome measures. So we had this really great opportunity, and I'm going to talk about it here, where we worked on improving health literacy knowledge, behaviors, and competence. So this is an example of something that leadership was asking us to do. And this made it a lot easier of a process because we had the leadership of our primary care clinics asking us to do this training. So this was part of patient-centered medical home designation that our primary care clinics wanted to improve the health literacy of the staff. That includes provider, any of the clinical staff, and to improve their health literacy knowledge, behaviors, and competence. So 25 primary care clinics and training all of the staff. And if you see over to the right, the distribution, that's from customer service, medical assistants, nurses, clinic leaders, advanced practice providers, and physicians. So, you know, when you're looking at everybody who is talking to, taking care of, giving directions to people in a healthcare setting, they can all benefit from understanding how to clearly communicate about our processes that happen within our healthcare system. So what we did and how we measured this was, first, if you see on the top of this bar, there's a pre-training survey. And then we did a post-training survey and then a 1 year after survey. We did a basic training, which was an online health literacy module through our Children's University, which is just an online system that you can assign people and you can see whether they completed the module. And then 2 days afterwards, they received an email that said, you know, I want you to remind yourself what was one important thing that you learned from this. And then we did an in-person booster session with an application of the material. How we did this was actually like a quiz show kind of session, and that was conducted by the leaders at each of the individual practices. And the people worked in teams to answer some of the questions that solidified the information that was in the CU module. And then after those two items, then there was a post-training survey. And then the sustainability efforts were through leadership a lot, with leadership presentation, strategy, or health literacy strategies flyer. We have safety coaches at Children's who people have signed up for that within each of their clinic sites. And so there's reinforcement through the safety coaches talking to individuals, clinical practice coordinators rounding. There was some health literacy scenario lunch and learns, and that was completed over the next 10 months afterwards. And then a survey was done at the end of that. So what we found was we improved awareness. So any of those asterisks on these are significant improvement. So we improved people just understanding what is health literacy. So we improved that both in the post-training and the 1 year post-training. We improved people's ability to understand the meaning for patients, both in the post-training and the 1 year post-training. We improved people's understanding of how is health literacy tied to health outcomes, and also knowing whether patients understand. So we are able to just improve their awareness. And then we're also able to improve their techniques, not with plain language. So people were already doing a pretty good job. About 45% were saying that they were using plain language as part of a technique that they used on a daily basis. So we didn't improve that much. We improved, at least in the post-training, whether people are limiting the use of forms. The third set of columns there is whether they're limiting information and when they speak. Checking for understanding, and that fourth set of bars there was improved at 1 year post-training. And then just their confidence in using those was improved both in the post-training and 1 year post-training. So the important things that we learned from this is that, you know, we were able to improve staff knowledge, reported behaviors, and confidence using health literacy strategies. But we also developed this method at our local institution that we can translate into other clinical environments. So we have a method now that it doesn't have to be just simply health literacy, but a health literacy type topic that we can translate and use in other ways when we're working on other health literacy type of focused activities. So this was really a great kind of leaping spot for us to show administration that, you know, we've got a problem and we have ways that we can improve it. And here's another way that I'm going to talk about that we were able to improve it. So this is a program that has been going on for a very long time to work on health literacy focused asthma education at Children's. So we had a really broad smattering of asthma education materials available. And so what we really needed to do is kind of bring it all together. So we used asthma education from our community partners, asthma education that we had, everything from our pulmonary, our asthma allergy clinics, brought it all together and used our best health literacy techniques, worked with our ed services department and all of our specialists to come up with a program of written information, video information, which we used and contracted with a national video provider to give us images and then whiteboard videos that match the images and use the language we wanted. So it wasn't just, you know, some video that we contracted with. It doesn't actually match what's on our sheets and what we are teaching, but it uses all the words that we wanted to, and then use health literacy techniques. And then when we taught this, and when we worked on an improvement program with this in the emergency department and in inpatient and now in our specialty clinics, we're also teaching health literacy techniques along with it. So we're not only giving you the health literacy materials, we're also saying, okay, here's how you ask open-ended questions about asthma. Here's how you do teach back about asthma. Here are the plain language things you should ask. Here's how you limit information and give action-oriented information. So those are kind of the health literacy techniques that we use. And the overall goal and the global aim statement of this work is to improve the value and equity of asthma care. And the project aim statement wasn't necessarily to look at that overall outcomes, but really just to increase the proportion of children and families receiving the asthma educational intervention, video, written and verbal education when they're seen in the ED or hospitalized. So we focused on those. They were on that acute state. So they were coming in, you know, as having a big problem. And maybe that's because I'm an emergency department doctor. And of course I focus on the emergency department first, but I can't help myself. So what we found was we were able to increase the amount of parents receiving video asthma education in the emergency department. So we went from having 0 people getting a video to having about 33%. So this is a control chart. And if you look on the y-axis, that's a percent of parents receiving video asthma education. On the x-axis is over time, so beginning in January of 2018, and this just goes through April of 2020. And then each of those boxes is a notation of kind of those interventions that we did over time to try to improve that video use. And you can see each of those dots is the monthly percent of each of those parents receiving video asthma education. So we were able to go from 0 to 33%. And that's just to show you kind of what we did in the emergency department. We did a lot of that work. You'll see the same kind of stuff in the hospitals. I probably should have used the hospital ones because we did even better in the hospital. because they're there longer. So even up to 65% of the time in the hospital, they're getting their videos. So what we found was, and I just think this is fascinating and wonderful to look at over time. If we look at again so this is rehospitalizations. So the units that are here are our primary respiratory units. And those are the primary units that we focused on in our pilot work for the asthma education. And so on the on the y-axis is the percent of discharge that were readmitted in a year. So we looked a full year out, because a lot of those kids who either come to the emergency department or are hospitalized are more likely to come back in that next year, because there's a reason they were there in the first place, is that they just don't have good baseline control. And so we looked at about baseline 22% of kids who are hospitalized for asthma come back in that next year. So when we finished our asthma education in the emergency department, the last improvement point was here, the A point, in August of 2018. And we can see that we drop after that. So all of our improvement went to here, we dropped down to 11% after. So just doing it in the emergency department, because those kids are coming through the emergency department to be hospitalized, we affected rehospitalizations of those hospitalized kids. And then the work in the hospital took place, the B, C, D, as you can see them labeled here, and we took it down even further to 3%. So COVID messed with our data, of course, because kids, during COVID, our rates of asthma, emergency department use, hospitalization dropped precipitously. Kids weren't outside, they weren't exposed to allergens, they weren't getting viruses, and we were not seeing the numbers. And so it's a little bit hard and fuzzy to tell kind of after this point where we're at. But we can see pretty clearly that we had a precipitous drop after those actions that we took. And there wasn't anything else that we were doing with our hospitalized or ED patients specific to asthma that would have been a part of this either. So we saw some really great improvement in our rehospitalization. So we weren't just giving them materials, we actually saw those outcomes we were really hoping to see. And I think even broader and bigger, we have really great system-wide asthma information or asthma data that once we really get this spread through our system, we're going to really see the outcomes of this and see how it's really affecting the health outcome of more of a broader population of our children. The data isn't perfect in this chart, but I think it illustrates a point, and I hope we'll get a little bit more information as we keep moving through this. But this is looking at the readmissions also by race ethnicity. So the blue line is Black, not Hispanic. The green line is Hispanic, and then the white is not Hispanic. So we can see at our baseline here, and I apologize, they're not noted, which would be here up until August of 2018. We see that the Black, not Hispanic children have a higher readmission rate. And we don't see a lot of change here, but as we move and have those hospitalized kids, as everyone is coming down and having lower rehospitalizations, so are the children who are Black. And our hope is over time, by addressing health literacy, we're actually helping to address that inequality. So that's one way that we can, as a health system, actually affect their health outcome, is by giving them information in a way that they and their family understand. So what we, from this work, we really found that asthma education given to children and families at that point of an acute visit is really effective in helping and improving that health outcome. But what I also think, and what I told leaders, is that you see that when we take our health literacy focus and we put it on something like asthma, we can actually affect it as an organization. So it isn't just one thing. We can actually take what our health literacy work would tell us we can do and impact us as an organization. So how does that look? So how does health literacy improving our organizational health literacy actually help improve our health outcomes and actually also provide health equity? So if we think about health equity, and there's lots of different models, and this is a really simplistic view, I know, but we think about it as simple as it comes. Here we have these health outcomes here on this tree. Let's just say it's emergency department use, because I'm an emergency department doctor, and clearly that's all I think about. But we know people, when they don't have control of their disease, they come to the emergency department. And we may not need a lot to get this person to help them get their disease under control so they don't come to the emergency department. But we need to do more for this person on this side. But there is something that helps everyone. So we're giving an equivalent treatment. It actually helps everyone, but it also helps that person in that greatest need. And then we need to give that extra step. So what is that extra step that we need to help these others with, but also have that foundation? So that's kind of how I portray it, as what is that foundation and what's that step up? And so what does that look like from a health literacy perspective? So the Health Literacy Foundation for Health Equity, you'll kind of see some of those 10 attributes in here, is leadership support, integrating health literacy and health equity into quality and operation activity, health literacy staff and provider training, having low literacy written materials and forms, providing low literacy discharge instructions, and clear health system navigation. We should be doing this for everyone, right? This is universal precautions. Everyone should be getting these things. But then what does it mean to have this step up? Like, what are we doing for people that need more? So that could mean multimedia low literacy education materials. So thinking about our asthma education. For those that are coming in for that acute visit, because their disease isn't under control, we need to do something extra. So, and that also fits under the disease or situation specific health literacy needs. Providing shared decision-making models or education materials. And we can't underestimate the impact of navigators, coaches, advocates, coordinators of care, and deploying them, though, not to everybody, but to those who need them most. And deploying them to people who are in those higher risk states so that we can do that in a cost-effective way, right? We can't give navigators to everyone, but who can we give them to? So I'm going to just close with kind of some of our current work to transform medication safety by improving organizational health literacy. And our work is to try to decrease medication harm events across the care continuum. And we're doing this by improving staff discharge medication instruction, decreasing parent medication administration errors, and then trying to do this equitably for parents who have low health literacy. And we're doing this overall quality improvement design with all staff and provider training of best practices in clear medication communication. We have our program design. We've done it, we've been effective, but we're doing it with medication rather than just with health literacy. We're providing improved EHR upgrade to provide clear medication communication, which we're currently rolling out in the emergency department. And then we're implementing a risk stratification and high intensity interventions. And that's going to help us understand how we can provide this standard bundle to everyone, but in high risk situations, they get that standard bundle. They get our clear medication communication, they get our written communication that's improved, but then we give them more in those higher risk situations. And what that looks like is, it looks like intensive education at discharge. It includes pharmacy follow-up or video calls after hospitalization or emergency department visit, intensive case management, navigators or coaches. And that can include connecting to existing, like Medicaid, which currently has some. So we're already seeing in the emergency department, this is a control chart showing our experience scores since June of last year. With the percent of talk box, did you receive easy to understand instructions about how to give your child medicines? And we can see that we've improved that score from 76% up to almost 81% of parents saying that they did. So we're already seeing that we're improving our experience of medication teaching through the work that we're doing. And we completely expect that to continue to improve. So key messages: we can improve our equity, quality, safety, and experience of our care by awareness, local change, system change, and addressing these issues from a health literacy perspective can help understand part of that root cause, maybe achieve an improvement goal you haven't been able to obtain, and potentially address health equity from a perspective that we can actually address as a physician and as a health system. And I'm going to leave you with our strategic planning. These are our strategies that we use, and I keep giving these to every leader that will listen to me, that we should be giving clear communication in all interactions with families. We should equitably being able, those we serve, to find, understand, and use health information, and improving the value of our care by providing information at understandable information at key times to improve health outcomes and management. So thank you all for your rapt attention at this late hour as it gets dark, and I really appreciate you having me. George.
Area. But we also have
Can't hear the question.
I'll repeat.
And what I understand, there's an applicable and that really confuses them.
Oh boy. So Dr. Lang is asking me how to address misinformation. I think kind of to summarize it.
Yeah.
For instance, like there are physicians out there who, don't believe in immunizations and are giving, false information. So so we'll just talk about the immunization hot button issue. And it's hard to address immunizations from a knowledge perspective because it's a belief. So, and you can't fight a belief with more knowledge. And so a lot of times you have to come at them from, where they're at and find out where this belief is coming from and try to address it either from that belief structure. So let's say that they hear from members of their church that it's the such and such, or there's a pork product, or there's and try to address it from that belief structure rather than trying to address it just with medical knowledge. So immunizations are, but as a pediatrician, such a hot button issue. And I will say, like, as a ER doctor, I often talk about this from the perspective of tetanus. So I'm actually able to convince a lot of people who've never been immunized to immunize their children in the emergency department for tetanus. And a lot of it is just meeting them where they are, finding out what it is that they're concerned, worried about. But, addressing misinformation is extremely hard. So clear, factual, timely. So some of the things that our CDC maybe could have done a really good, much better job at. All of those public health communication things are really important. Kind of getting ahead of the message and keeping it, consistent, clear, timely, factual, consistent. Those are all really important too when you're talking about like public health messaging. Yeah.
So we have sort of a two-phase thing here, sort of a universal precaution sort of system. Then also a few slides ago, you had a thought about folks who need more work than other folks. So do you have a method of identifying them?
So that's a great question. So he was asking, we have this universal precautions, and then what about those who need more help? How do we identify them? So I think it's a maybe case by case, disease by disease basis, how you might identify them. So just as an example for our medication work, we went to the literature. So individuals who have over 5 medications, we also went to our local data, injectable medications, chemotherapy agents, compounded medications. So we found those that created a lot of error, and those are what we consider to be kind of high risk situations. And then low health literacy, which we do as a screening measure at Children's. There is a 1-question screening measure that organizations use that can be asked, and we've been asking at Children's since 2012, and can be asked by any health care organization. So I would advocate that can be used actually to identify individuals that might benefit from something like that extra step.
To those people who aren't familiar with memory research, can you explain what chunking is?
So did you guys hear that question? Everyone hear that question? What is chunking? So chunking is one of the health literacy techniques that we use to help people remember information that you give them. When you're giving them lengthy information, you break it up into smaller, more digestible pieces of information. So when we think about this, we want to keep just a minimum of, or a maximum of like 3 kind of pieces of information in each of those chunks. And then at the end of each of those chunks, you go back and you ask and stop, what questions do you have? Or perhaps do some teach back about what you just taught them in that section. So if you might think about, let's say you're a patient that's learning about type 1 diabetes for the first time, think about that amount of information that you have to go through. You don't sit and learn about that for 16 hours straight. You're learning about things, in hour snippets, and each one of those has got to be in, small increments at a time. So you have to chunk up, lengthy information. Yeah. Yeah.
Exercise that you described, or whether that when you were able to convince your leadership to underwrite the cost to do that training with her.
And that like the clinic training?
That when you did the
like the staff training?
Yes.
Okay.
Yeah.
Yep. So the question was, how did we fund this? I'll just put it that way. How about that? So a lot of this work has been done by committed individuals who do this as an extra part of their job, including myself. Until a year and a half ago, I didn't really have any time funded by the hospital to do any of this work, which clearly is a lot of work, because a lot of this is my work, plus some of help from others. So when it came to doing like the staff training in the clinics, so she was asking specifically, do we have grant funding for that? We did not. The CU module, like our module was created by our Ed Services Department. So that was funded by the approval of our institution for our Ed Services Department to work on it, which took time for them to do it. But it was, internally funded in that way, that that our Ed Services produced it. And it was just, created with the work of some of the clinic leadership, and then our health literacy, work. So my co-director is a safety specialist and clinical nurse specialist, and she was the one who did a lot of that work in coordinating and creating that. So.
Follow-up question. So were the physicians relatively receptive to this, or did
No, they were very receptive, because it just came as we're all doing this. This is kind of part of our patient-centered medical home designation. She asked, were the physicians receptive to this? And I said, this is part of the patient-centered medical home designation. And I think it's a really interesting question, though, because I think it's difficult to get physicians to do things like online modules and things. And personally, I'm not, all that great at actually completing them. So I will tell you what I did recently for our medication work. Is we have this CU module, and what I did was I did a CME event with that for our physicians, and that's what I'll probably do when we do it in other sections too, is I do it as a CME event. So then physicians are getting their CME out of it, which there's no reason why they shouldn't, because it's, it's evidence-based, and, I'm there telling them about it, so why shouldn't they get CME out of it? And then we're not asking them to do a module, and they can learn from me. Rather than doing it from an online program. So I think if whatever we can do for physicians specifically, I think whatever we can do to give physicians credit for the work, including MOC Part 2, which we're also doing. So I applied for MOC Part 2. Wait, that doesn't make sense to other people. Well, Yeah, does that make sense to everyone? Is everyone else doing MOC? I guess I'm thinking about it from a pediatrics perspective. So everyone's doing it, right? So with, yeah. So I applied for part 2 MOC credits through MCW, essentially ongoing. So to say, as we start working with other sections, that I can give in perpetuity, give people credit as they would go through this and go through the process that I asked them to do as part of this quality improvement work with medication. And they can get MOC credit for participating. So I'm a big believer also in getting MOC credit for physicians, because if they're taking part in the quality improvement work, they're looking at the data, they're generating ideas, then there's no reason why they shouldn't be getting credit. Yeah.
So then for all of us participate. And I think most of us, all of us think we are and teachers are patients. So often we find ourselves having to do an explanation or maybe all the way through and we realize that it's not just individual. So you mentioned that you have some particularly you can assess the level of person's health literacy before you launch and then do its work.
Sure. So question was, what would we do about health literacy assessment kind of on a clinical basis? So the screening question that we use is a single item literacy screener called the 2 question. It's how confident are you filling out medical forms by yourself? So the answer to that is kind of a screener for health literacy. If you were to really, want a very accurate assessment, because that's an okay assessment, it's a screener. If you want a really accurate assessment, there is a free tool that actually was developed by Pfizer, but researchers developed it. Very well thought of in the health literacy community, very accurate as a screening tool called the newest vital sign. It's an ice cream label. You ask people to answer questions. If I was to have lengthy education with somebody, that would be a tool that I would want to use. It literally takes 2 minutes. Newest vital sign is the name of it, is the tool. But on a daily general basis, screening probably doesn't have a lot to do with, what we do with individual patients. It's more on that system level of kind of applying resources. Like, unless we're going to be able to do something drastically different for someone, like I'm going to really be able to give you some good follow-up, a navigator, or something based on that question, it's probably better just to do some teach back. So teaching them information and then asking them in a way to repeat it back to you, or to, kind of discuss, or what are you going to do when you go home, or who else helps you take care of your health? How are you going to tell them about what the plan is for your diabetes? Or, I just want to check back in and see how we talked about this, and I know I told you a lot of new things. What are those, next 3 steps that you're going to take when you go home? So that's probably on a daily basis what the best thing is to do, to really check in and see how they're doing with the learning. Yeah.
Health literacy is sort of an equation which you have communication, which may be above the heads of the target, or maybe brought down to something that gets is understandable by the target, and it's also the education literacy level of the patient, of the target. We've been addressing mainly the communication package coming from the healthcare provider side.
Mm-hmm.
Large healthcare organizations hold the keys to teachable moments and credible teachers. How do you see emphasis on a bringing up of the health literacy of the target audience being changed? Of corresponding to this new role that healthcare organizations.
The question was, what do we do about individual health literacy? Maybe is that a good paraphrase? Like how can we, as maybe even as a society? I mean, I think that's a huge question that, there's so much that we can do as a society to improve what we do in our education system when it comes to health, and what we do for our immigrant communities when it comes to understanding health. But I think there's some really fascinating work. So in Wisconsin, for instance, there is a organization called Wisconsin Literacy that actually grew this subsidiary, Wisconsin Health Literacy, out of it, because the Wisconsin Literacy works with literacy organizations, small literacy organizations throughout the state, which often are people who are learning English as a second language. And what they realized is there are so many of their learners that needed to learn about health, that then they understood that this is a huge issue that we really need to help our literacy learners learn about health. And so there's some wonderful programs that have been developed out of kind of those literacy communities, not only here, but I think it's Florida Literacy Coalition has put out wonderful programs of kind of how do we teach some of these English learners how to make a phone call to a clinic. Like, what is it like when you call a clinic? What do you know what to expect when you actually call the clinic? So helping them to understand that. So those helping our immigrant communities as well. And then I recently, at our most recent summit, learned about some work to try to improve digital literacy, digital health literacy. So, if you want to apply for Medicaid, to get your child Medicaid, it is an online application. You're not filling out forms, you're doing it online. You may not have internet, you may not have constant access to internet or understand those forms. So, trying to actually go through that process and not have the digital literacy to do that, trying to give people that capacity. So there's a group out of Minnesota called North Star who is working they have these programs that they've developed to help people develop their digital health literacy so that they can understand how to do these health tasks online, like how to get onto my chart or another, digital EHR portal kind of thing as well. So there's a lot of those different kind of programs out there. Is that what you're getting at for a question?
Well, it's a challenge because government-based education presumably is not quite so driven by financial outcomes as healthcare organizations would be.
Right.
You're describing limited resources for the healthcare provider,
Mm-hmm.
and indeed the organization